Hi everybody, it's Professor Miller. I'm going to go through the structure, function, and disorders of the skin. A lot of the beginning content is pretty straightforward, and I know you cover a lot of it during assessment, but I thought it'd be helpful to kind of go through it real quick and focus more on some of the alterations. I was going to go through this a little bit in detail with class. However, I feel like it might be beneficial to go through, sections like the burns, to help you with the homework and all that. So I'm going to kind of move through the beginning section relatively quick. In terms of skin disorders or alterations, whenever you see a skin lesion, the big thing too is knowing how to document this. And I know she probably talked to you about this in your health assessment course, because you really have to make sure you're documenting the proper terms. So we have, primary lesions or secondary lesions, and secondary lesions essentially originate from a primary lesion. So it's always from a secondary cause, essentially. So the lesion would be from a primary lesion. But the main reason, too, like I mentioned, is to understand how to document these, in terms of whether it's a papule or a vesicle. And once again, too, like a lot of the alterations go alongside with these lesions or the characteristics of it. Like herpes zoster presents with vesicles versus papules, if that makes sense. So it does kind of help you put it together with the disease state. So you can read through this, but obviously a macule is flat. So knowing big things like, is it flat or is it elevated? And, they're characterized by, whether they're the size and whether it's flat, elevated, or whether it's fluid-filled or solid. So make sure you kind of read through these and make sure that like a macule will be flat, it's less than 1 centimeter. This would be like a freckle. A papule is elevated, but it's firm. So usually a papule will be like a solid lesion, but it's still less than 1 centimeter. Patch is obviously bigger, so it's flat. It's like a macule, but just larger. A plaque, a good example would be psoriasis. So it's usually elevated, but it usually has like a flat top to it. And I'll show you a picture as we move through. But plaque, I always think of psoriasis with it because it's usually large areas and it's slightly elevated, essentially. A wheal, always think of like a hive. A hive is an example of a wheal. It's elevated. It's usually got edema there. Even when you do like a TB test, you're looking for a wheal there when you inject a TB test into the skin. A nodule, a good example is a lipoma, which is like a fatty tissue. So it's firm and it's elevated, but it usually kind of extends deep down into the tissue. But it's usually larger than like a papule. Vesicles are fluid-filled. They're smaller, so they're less than 1 centimeter, but they're usually fluid-filled. And like I said, that would be a good example of like a tiny blister or like herpes zoster. A bulle is basically a vesicle. It's the same thing, but it's basically bigger. So that would be like a large blister or like a burn. Pustule, a good example is acne. So the difference between a vesicle and a pustule is that it's purulent fluid. So a good example is like a pimple or acne. Cysts are basically elevated. They're typically fluid-filled. Sometimes there is debris in the cyst, like elements of subcutaneous tissue in there, but usually they're fluid-filled. Telangiectasis basically means like spider veins. That's all that means, essentially. So they're irregular lines from the capillaries from that. And remember, secondary lesions are always caused from a primary lesion. So they occur from another underlying disorder, essentially. Scale is kind of exactly what you would think it would be, like flaky. Seborrheic dermatitis is a good example of a scale, and I have that in our slides too. Lichenification basically is like a thickened area. That's like if a patient had like a chronic underlying dermatitis where they start to get thickening of that skin there. And a lot of times it's usually because of chronic itching in that area. Keloids, you will definitely see these. These are basically, they grow in areas where, like a previous surgical incision or a previous scar. But the key difference between like a scar, or a keloid is the keloid actually grows beyond the wound borders. So they start to get excess collagen formation outside of that wound and they actually look kind of puffy. And I have examples of that too. Scar is obviously just fibrous tissue. Excoriation means like an abrasion. A fissure, these are pretty common too. And even if you think about like if you have really, really dry skin, you might get a fissure, basically like a crack, in the epidermis and dermis. You'll commonly see this like with athlete's foot because of, like a fungal infection, and they'll actually get like essentially a fissure, like a crack in the skin. Anal fissures are relatively common, and sometimes that's can be related to constipation or dry skin. Erosion basically is like where they lose part of the epidermis. It tends to be more of that glistening moist because they lose that epidermis covering. And a good example, like if you think about a blister that a patient would have and it ruptured, like that skin that looks, that's underneath the blister covering essentially would be the area that you would call an erosion. And ulcers, basically when they have loss of epidermis and dermis, good example is a pressure ulcer. Atrophy, this is thinning with the skin surface, often it looks more like a translucent or thin tissue. It's very common in older adults. Even if you think about the older adults' skin changes, their tissue is very friable, and it's because of atrophy of collagen and tissue essentially there. So that's just what atrophy, remember what atrophy means from when we talked about at the beginning of the course. Pressure ulcers are very common, unfortunately, and the big thing as a nurse is preventing them. So honestly, you have to think about those patients that have those key risk factors there, whether they're incontinent, they have prolonged bed rest, or they're in a wheelchair. So prolonged immobility, essentially. They have pressure put on that skin, and it can decrease blood flow there, to the tissue. So then they end up with, or they're at risk for tissue breakdown, essentially. So anytime there's pressure on the skin or shearing forces, so shearing forces would be like transferring a patient or moving them up in the bed a lot. Any friction in that area or moisture. So like I mentioned too, like patients that are incontinent, or if they're wearing, Depends or diapers, obviously they're putting them more at risk for developing pressure ulcers. So the big thing is understanding risk there and who is at risk for developing ulcers. And I'll show you some other slides as we move through. You probably cover this in assessment because it usually is a big portion of assessment, but it is important to understand the stages because once again, you need to know how to document them. It does determine their treatment with patients, and a lot of times with pressure ulcers, they will have like a wound care nurse on board with the patient, and sometimes even infectious disease because a lot of these can get obviously infected too. So there's different stages. The first one's non-blanchable. So there's no opening in the skin. It's intact. And I'll show you pictures because I think a picture puts it together better. Partial thickness basically involves that epidermis or dermis. Full thickness is basically loss of that subcutaneous tissue, where full thickness is when they start getting down to muscle, bone, or the supporting structures. And it's not uncommon to see this, unfortunately. And we do term, pressure ulcers as unstageable, unfortunately, too. This would be in a case where a patient has, severe tissue necrosis over the wound. You can't really stage it because there's so much necrotic tissue over it that you can't tell how far it goes down. And a lot of times they actually will debride the wound in order to look at, in order to assess how far down it is, essentially. So sometimes they're actually unstageable until we actually debride it. But it is important to know this because I know, a lot of times these are questions that are asked on boards too. So preventative techniques, so frequent skin assessment, that's the huge big thing. As soon as you notice any redness on a patient, on their bottom, in the coccyx area, on the heels, and I'll show you an image on the next slide. These are frequent areas that you'll see it. But big thing is making sure that we're repositioning patients. They can even get them on the back of the head. If they're laying in bed and they're immobile or unconscious, obviously they're at huge risk. So we have to make sure we're repositioning them. And usually, as a nurse, there's guidelines of how frequent you're repositioning your patient, and you document that. Pressure reduction, removal, or distribution. So it's basically removing pressure off that one area. Elimination of moisture, so making sure that, that they're not sitting in, anything with moisture, whether it's a dressing under, their bottom or they're in Depends. Obviously, you have to make sure you're assessing that. These are common areas that you will see wounds, very, very, very common on the tailbone or the coccyx area, because that's just an area of pressure. So if you think about the pressure points of when a patient's laying or sitting in a wheelchair, these are where they occur, unfortunately. So when you're doing an assessment, always look at these areas. Do you see any redness there? Because as soon as you see redness, they're already at risk for developing a wound or pressure ulcer. They come on very, very quick. elbows, shoulders, back of the head, knees, and even in the OR, like a lot of times positioning is a huge thing, even in the OR, because those patients are, they're sedated, they can't move, and over a few hours they can actually develop tissue damage. So positioning and proper positioning is very important. Wheelchair patients too, even the shoulder blades from pressing on the back. These are just images. I think it puts it together better when you look at it. But grade 1, usually they, look at like partial thickness, full thickness. Grade 4 is extensive destruction down through tissues essentially. But at the beginning, you can see like it'll just be red. So if you see any, instances where it's just red like this, obviously that's a red flag. They're already developing it. There's already tissue damage there. So that would be like a non-blanchable. And when we say non-blanchable, that means if you were to push your finger on it, kind of like you do with capillary refill, like you'll see that return of blood flow. So non-blanchable basically means that if you push down and release, it's still going to maintain that redness there. When you start moving down to partial thickness, they basically have loss of the epidermis and sometimes into the dermis. So it's more superficial, and it could be like more of like an abrasion that you would see with the, the pressure ulcer. When you start moving down to like a full thickness, they start to have tissue necrosis there. So they can have, subcutaneous tissue involved. They may extend down even to that underlying fascia. And so the fascia is kind of like what's covering the muscles, like a supportive structure. So they start to have, they're not down to the bone or the muscle yet, but they're right above it essentially. Grade 4 is basically when they start to having damage to that muscle or through the fascia. They can have a significant amount of tissue necrosis there. And basically it's kind of like a full thickness loss where you're going down through the dermis, the epidermis, the dermis, and even the subcutaneous tissue down into the muscle or bone. In terms of other alterations, like I mentioned at the beginning, you will see keloids or hypertrophic scars. Keloids, basically, like I already mentioned, they have like excess collagen in that area. They tend to be elevated. They tend to be firm. But the big thing with keloids is that they extend beyond that original site of injury. So they start to extend outside of that scar. You can have hypertrophic scars, basically where, they're more red and raised, but they're not quite as bad as a keloid. A keloid's actually when they're starting to extend beyond that. Both of them are caused by excess collagen formation during connective tissue repair. This is an example of a keloid. So as you can see, they start to, obviously, like if they had an incision, it would just be like a thin line. So they start to extend beyond that initial wound, essentially. So it's pretty common. You'll see it fairly common. Other things like inflammatory disorders, this is actually relatively common. Different types of dermatitis or eczema. Eczema is very, very common. You see it a lot in kids, too, in the pediatric population. And it goes hand in hand with, like when we talk about like an inflammatory disorder, like eczema, it goes hand in hand with like asthma and allergies because there's an immune component to it. So even when you think back to that initial content that we discussed in inflammation and hypersensitivity reactions, a lot of this kind of relates to that. But when they have this, a lot of times, like I said, they usually, especially peds, they tend to have like asthma, allergies, they all go together. But it's very, very common, and it's, has an underlying inflammatory component to it. A lot of times it's very itchy. Many times these patients will get, they tend to get them a lot in the folds, like by their arms, like where your elbow would fold on the inside portion. But they tend to have a lot of itching with it. But it's more chronic, so sometimes they get like thickening of the skin in that area. But it's usually really itchy. Other things too, like contact dermatitis, very common as well. However, this is like when we think back to like hypersensitivity reactions, this is more of like a delayed hypersensitivity. So it's not that systemic like IgE response. It's more of a topical type dermatitis. So this would be like patients that are exposed to, a good example would be like from jewelry. Like if you had, people are sensitive to jewelry and they'll get contact dermatitis from it. Another example would be certain soaps or certain detergents. Sometimes patients will get contact dermatitis with it. So it's not really a systemic response. It's more of like a topical inflammatory disorder. So it's basically when they have the T cells that are activated with it and they get sensitized to the antigen. But a lot of times they'll present with like a rash in just that area. So it's not all over the body. It'll be in that one little area. But they do get swelling with it. They get pruritus, which is itching. And they can get like where they're vesicular lesions where they have little like vesicles there essentially. Sometimes it just looks red like this and it's just real itchy like that. But a lot of times we'll use like topical steroids to treat it. If it's severe enough, sometimes we'll use oral steroids to treat it as well. Irritant contact dermatitis, very similar to the one I just mentioned. It's basically the same type of thing. It's innate immune response, so it's basically due to like soaps or like jewelry. It's the same kind of thing I just went through with this one essentially. This could be too, like, it might not necessarily be like an immune reaction. It might be like an irritant. Like, so let's say you've used a really abrasive soap and you get really itchy or you develop a rash in the area. So it's not necessarily like an allergy. It could just be from irritation essentially. So that's kind of the difference between the two of them. But the symptoms are very similar to contact. Atopic dermatitis. This is like eczema essentially. So it's got a very, very high link with asthma and allergies, like I kind of mentioned when we talked about that with eczema, because they're pretty much the same thing. It is associated with an IgE antibody response. So this is more of a systemic thing. So that's why they end up, it becomes chronic, unfortunately. And a lot of times it's common in kids, they'll outgrow it. But they'll get itching, and like I mentioned before, you'll commonly see it like in the folds of skin, so like behind their knees, in the flexor folds of their arms. But it's itchy once again. But you'll see this a lot. It's pretty common. And that's usually treated with like topical anti-inflammatories or topical steroids. Seborrheic dermatitis is very common as well. Essentially, like in the infant, when you hear the word cradle cap, that's essentially what seborrheic dermatitis is. And it's actually related to like a underlying fungal infection too. Basically, they get like that scale or like a plaque on top of the head. It's like a chronic inflammation that comes alongside with it. Not uncommon for them to get it kind of by their eyes as well, but it's very common in the head. And usually, after washing and, brushing the baby's hair and all that, usually it resolves over time or they outgrow it essentially. But that's basically cradle cap. Stasis dermatitis and seborrheic dermatitis. Stasis dermatitis is actually very common. On the left, you'll see when patients have like venous insufficiency where they have pooling of venous fluid in the lower extremities, you sometimes will see the patient develop like a characteristic rash or discoloring on the lower extremities. Unfortunately, sometimes patients have it very severe where they actually will develop ulcerations or wounds. These vessels will become very fragile, and because of the rash that's there or the blood pooling, they sometimes will open up. So sometimes they're at risk for wounds as well. Seborrheic dermatitis, kind of the same thing that I just mentioned with like cradle cap. It's the same kind of thing where patients can get it on their face. Usually like around the nose you'll see it, or by the eyes as well. Papulosquamous disorders. This would be what we would term like a psoriasis. So psoriasis is actually like technically an autoimmune disorder. It's very inflammatory. These patients are actually at risk for psoriatic arthritis as well, and we'll talk about that in musculoskeletal. But they tend to have like a significant overgrowth or significant cellular proliferation. So they tend to develop like these thickening plaques essentially in the skin. It is mediated by like your cellular response or immune system essentially. So basically they start to get dermal thickening in that area. They have huge turnover of the epidermal cells. So basically that's why they develop these really thick plaques of skin essentially. So these cells the epidermal cells don't have time to mature or adequately keratinize. So they end up with like an abnormal growth of plaque or tissue essentially in that area. They tend to have like a silvery appearance on the top, so they really have like a red base. And remember I mentioned this would be like a plaque, but you'll see them usually like they'll look red, but they also will have like a whitish silvery appearance kind of on the top as well. Here's an image of it. Like you can tell they'll have like a red base. These would be considered plaques, but you'll see like the whitish silver on top of them as well. So that's psoriasis. A lot of the medications that we use for like rheumatoid or psoriatic arthritis, like Enbrel or some of the biologic meds that you'll talk about in pharm, but they can be used for psoriasis as well. It depends on how severe it is. In terms of infections, these are another thing that you'll see commonly. Folliculitis is very common, and this is actually when it originates from the hair follicle. You'll see it commonly in people that have very thick, coarse hair, or you'll see it in the groin, where basically pubic hair, because it's thicker. They basically develop an infection right underneath the skin by that hair follicle. Sometimes they can resolve on their own with like warm water compresses, but sometimes they get pretty significant. Furuncles are basically inflammation by the hair follicles, but they're at risk for folliculitis essentially with this. And a lot of times too, I'll show you pictures on the next slide, it makes more sense. But carbuncles is basically a collection of them. So it's like a collection of furuncles essentially with infected hair follicles. I'll show you images of all these. Cellulitis is basically, it's very common. You'll see cellulitis a lot in the hospital. And sometimes it's not necessarily that the patient will have a wound. They might have like a very small abrasion or something like that. Anything that can introduce bacteria into that the tissue, they're at risk for developing cellulitis. And a lot of times it extends from that, the epidermis into the dermis, and it can even go to the subcutaneous tissue. So a lot of times with cellulitis, these patients are put on some hefty antibiotics. Erysipelas is basically more superficial. You'll see this somewhat. It seems like it presents more in kids than anything, but usually it's related to like a staph or strep infection. Impetigo is very common in kids, very, very common. You'll see it a lot around the nares, and I'll show you a picture of that too. But they usually have like tiny little pustules and crust over it. And a lot of times, a lot of skin infections in general, whether it's cellulitis, furuncles, or impetigo, a lot of them are related to staph or strep. In general, skin infections are usually staph or strep, essentially, with that. In terms of folliculitis, like I mentioned, so they tend to have like inflammation by that hair follicle, and this is where they're like you'll have your white cells kind of start accumulating there, so that's why they develop pus with it. A furuncle is basically like a boil. That would be like a non-technical term for it. But a lot of times on the surface, they'll have a tender papule there, essentially, or a pustule, because it'll start filling with fluid, or these white cells come to the surface, essentially. A lot of times, if it's a small lesion, a lot of times they'll open on their own. However, they can basically develop an abscess. So abscesses tend to have to be they have to be treated with an I&D, like an incision and drainage, essentially. So they'll open it up and let the drainage out. A carbuncle is basically where they have multiple furuncles, so they start to get multiple pustules at the top of the skin, essentially, with that. So it's essentially more severe in just a larger area. Furuncle, this is a good example right here. Like you'll see it too. It's kind of common in men because they have thicker hair. Or like I said, in the groin, you'll see them a lot too because it's usually that thickness of the hair is what predisposes them to it. And a lot of times the hair gets trapped under the skin and it just creates that environment for developing a skin infection or, a infection of the follicle. This is kind of how a carbuncle develops because a lot of times it starts spreading to the other areas or other hair follicles, and then they start to develop multiple furuncles, which is a carbuncle. This is cellulitis in a pediatric patient. You'll see those a lot in older adults where they present. Remember when we talked about like that inflammatory response where they have redness, warmth, swelling, or edema, or it feels warm or pain? Remember that huge inflammatory response that happens? That's why they present like this. So if you think back to when we talked about inflammation, that's why they have the redness, swelling, pain, etc. So that's what cellulitis is essentially. And a lot of times, once again, it's usually staph or strep. The big thing nowadays is that MRSA is more common. So methicillin-resistant strep is another factor that we have to think about with any of these skin infections because it's actually pretty common nowadays. Viral infections are relatively common as well. So anytime you see HSV, that's herpes simplex virus, and there's multiple types of herpes viruses besides even these, but HSV1 and HSV2 are the ones that you'll commonly hear about. It can be transmitted through infected saliva. HSV1 is basically cold sores. So when you see them on the mouth, that would be HSV1. HSV2 is basically genital herpes. So that's the difference there. Not to say that you can't get HSV1 there. It does happen, but usually when it's genital, it's HSV2. If it's cold sores, it's usually HSV1. The other big thing that you'll hear too with herpes viruses is chickenpox. So chickenpox is from a herpes virus. So anytime a patient has chickenpox, they're at risk for developing herpes zoster, which is shingles. What happens is when you have chickenpox, that virus lays dormant in your nerve root system. And as patients age or their system becomes compromised, or if they're immunosuppressed, they're at risk for developing shingles. So shingles is basically what we call herpes zoster. And it's caused by that same herpes virus, and it's caused from chickenpox. So you have to have chickenpox in order to get herpes zoster, essentially. So years later, it basically gets reactivated in that nerve root system, and then they get a rash in the area. However, with shingles, it can be paretic, basically itchy at the very beginning, but a lot of times they have a lot of pain in that area because it affects the nerves in that area. Some patients don't ever have a problem with herpes zoster, and some unfortunately will develop herpes zoster infections, reoccurrently. But that's why nowadays we use like the shingles vaccine to prevent this from coming on. But it's very, very painful. Basically, the other thing too is if you've never had chickenpox, patients can actually get chickenpox from patients that have herpes zoster, if that makes sense. And I'll talk to you guys about this just to clarify. But if a young child is exposed to herpes zoster in an older adult, they can get chickenpox from them, from like an active lesion. It's not that easy to get, but it can happen. However, now we vaccinate against chickenpox, so this is relatively rare because most kids are vaccinated for it now. However, babies are not vaccinated against it, so this is a risk. If you've had chickenpox and you're exposed to somebody with herpes zoster, your risk is not there because you've already been exposed to the virus. It's more of that patient that has not had chickenpox that can get it from patients, and I'll clarify this when we meet, but it can be contagious in terms of the patient that has not had chickenpox. This is what herpes zoster commonly looks like, and I would characterize this as a, like a vesicular rash. And the big thing with herpes zoster, it follows a dermatome route, meaning that you have dermatomes in your nervous system, and you'll talk about this when you get to neuro, but nerve roots essentially extend out, and I'll show you, I have a chart on the next slide, but you will see it literally follow those dermatome roots. I very commonly see it on the thorax. It's very, very common to see it like on the posterior side. Sometimes it'll extend into the front. The big thing with herpes zoster is it's usually unilateral. You will not tend to see it, or you should not see it, on both sides of the body. It'll present exactly like this, where it's on one side. So usually it's on one dermatome root, and it'll follow a distinct pattern like this. It may not spread that far, but it'll follow that dermatome route. In terms of how they present, a lot of times they present with like a prodromal phase, like they may not feel well. This will happen usually before a rash comes on. And sometimes it's hard to figure this out because patients that have never had it before, they just don't feel well. And at this point, they don't have a rash, they don't have any lesions there or anything. But they may have pain, headache, malaise, or they just feel, crummy, essentially, like a typical viral syndrome. And then sometimes they'll come on where they'll start to get pain in the area, like over that dermatome root, and they may not necessarily have a rash at that point, but they may have, a lot of itching in the area, or they may have deep pain. Sometimes patients literally feel like it's internal. They may feel like they have internal pain, like chest pain. In fact, when I talk to you guys about this, I'll share a story with you about it too, or a couple stories with it. But a lot of times with it, after that kind of starts like that, then all of a sudden they'll see a rash there. And it may not be this distinct. Like they may only have a few little dots there. Like it's very common to only see like a few little lesions. And you want to catch it early. The earlier you get them on an antiviral agent, the better off, or the better the outcomes are essentially with patients. You can even get it on the face. And this is actually, very, very problematic because it can affect the optic nerve. In the patient's vision. So anytime you see it around that nerve root tract that affects the face, or any lesions that are in that area, they require an ophthalmic referral essentially with that. This is just another image. Like you can tell, see, these are dermatome roots. Like when they come out of the body, like you'll see it's in half. Like this dermatome root coming out of the peripheral nervous system only feeds that half of the body. So it should not be on both sides. You will see a characteristic rash on one side of the body. Like if you look at this gentleman's face, you can tell it's not on this side. It's literally on this part of the head with that dermatome root. But But like I said, it can affect the eye. Very common, like I said, it seems like they tend to present a lot in that thoracic area. I've seen it a lot on the face though too, but it seems like the back and thoracic area is very common with it. I have seen it in the legs, but it's not to say you can't get it done there, but it is common up here. So anytime you have a patient, I'll share the story with you about it in class though. I will talk about it more. In terms of warts, this is from HPV. So any HPV virus, human papillomavirus, is what causes warts. And remember, we kind of talked about genital warts and stuff like that, or cervical changes. There's just different types of papillomaviruses that target certain areas. So it's the same thing. It's caused from the human papillomavirus, but it can include things like common warts or plantar warts. Plantar warts are basically at the bottom of the feet. They're hard to treat because they are so thick and the tissue's thick in the area, so they are difficult to treat. But it's all from HPV. The technical term for genital warts from HPV is condylomata, acuminata. Don't remember about memorizing that. We've already talked about genital warts anyway. So fungal infections, very common, like I kind of already went through. We talked about it at the beginning a little bit, but basically, these are very superficial, and they're caused from dermatophytes. Dermatophytes are just generally fungal infections. So the other term that you hear is a mycosis. Mycosis just means fungal. Anytime you hear a fungal infection of the body or the skin, it's called tinea. So tinea, whether it's on the head, tinea capitis means the head. Capitis is basically like, when you think of capitis, it's the head. Tinea manus, people don't really talk about that. Usually when it's on the body, we say tinea corporis, meaning the body. Tinea pedis is the foot. Tinea curis is basically in the groin. That would be like jock itch, essentially. Tinea can occur under the nails. We usually call that onychomycosis. That's basically like a fungal infection of the nails. The big ones that you're going to see is tinea corporis and tinea curis, tinea pedis, and then on the head in babies. Babies, the one on the head is pretty common. And that overlaps with like seborrheic dermatitis as well, like I mentioned at the beginning. But any body mycosis of the skin is tinea. Just remember tinea. It is not uncommon to see hair loss over that area. So like if a patient has alopecia and it's kind of defined in an area like this, it's a lot of times it can be related to a fungal infection. And a lot of times we'll do like a skin scraping of the cells, send it out and look and see, if it grows anything or if it's like a fungal infection there. But it's treatable. That's the thing. Tinea pedis, which is basically athlete's foot. Like I mentioned at the beginning, you can see fissures. A lot of times with patients with tinea pedis, they have moisture. Like you'll see it in athletes a lot because they wear, their feet are sweating. So a lot of times it's making sure that they don't have a lot of moisture in their socks, or they're wearing the right type of socks essentially too. Because it can basically get flaky like that, but sometimes it gets really raw and excoriated and they can get fissures there too. Sometimes they're very itchy, so tinea can be itchy. Tinea corporis, this is very common in the pediatric or adolescent patient. It's commonly known as ringworm. Ringworm, when you hear that word, I think people freak out when you say ringworm. All it is fungus, and anytime you say ringworm to somebody, they freak out. But the reason why it's called ringworm is because if you look at the presentation of it, there's a distinct ring around it. So if you ever see a lesion that has almost like a central clearing with a red ring or red border around it, and it kind of looks flaky almost. These don't tend to itch much. They can itch. I shouldn't say that, but sometimes they burn a little bit or they're just irritated. But it's tinea corporis. But when people hear ringworm, they think it's like some crazy worm that's infecting them. And really all it is like a fungal infection. And we treat it with antifungal agents, essentially. Very common, and we talked about this before, about like a candida infection from Candida albicans. Basically, you see this a lot in babies, like when you hear the term thrush. Thrush is basically a candida infection on the tongue in a baby, and it's very common because a lot of times their immune system is not fully developed. That's why it's more common in this, the younger patient under 6 months. They're just more predisposed to getting it. Patients with diabetes, they're more apt to developing candida infections, even whether it's in the mouth or under, in the groin or under the breast, they're more apt to getting that. Environments that are very warm, that's why even like when you talk about like fungal infections on the body, like even tinea, it's those areas where there's more moisture too that you'll see it. You can get thrush in the mouth with patients that are on very hefty antibiotics because it kills your normal flora. or basically kind of wipes out your normal flora there. And they get an overgrowth of candida in that area. So you might see this even in patients that are, in the hospital that develop, that are on really strong antibiotics. And usually we'll treat them with like a swish, or a mouthwash essentially that has an antifungal agent in it. Tick bites, I'm sure everybody's probably heard of tick bites before. But the big thing with ticks, and this is not always the case, it's usually if the tick is infected with Borrelia. And so you can get a tick bite and not necessarily have a problem, essentially, is what I'm trying to say. However, there is a huge risk of developing this. So anytime a patient gets a tick bite, they want to make sure we remove the tick. There's different types of ticks depending on where you live. But the big thing with a tick bite is a lot of times these patients will present with what we call a bullseye rash. A bullseye rash is like you have a tick bite. Some patients don't even know they got bit. The tick will fall out, and then all of a sudden they see a bullseye rash like this. So bullseye meaning it looks like a bullseye. It'll have a red center, but then it tends to have a clearing, and then it has a red outline. But it's important to ask patients about like their history. Were they in the woods recently? Do they, what do they do for a living? Are they a hunter? Where do they live? Because it makes a difference. So not all tick bites can, cause a disseminated infection, but there is a risk there, definitely. And sometimes if they will send the tick out to get checked, if they still have the tick, essentially, for that. But they can have a localized like cellulitis infection. They can have a disseminated infection where they get really sick, with a systemic response with it. And unfortunately, there is a late persistent infection that can develop too. And it's almost like they present a lot of times with like chronic fatigue. They can have joint pain. So a lot of times they'll present with what's Lyme's disease. I'm sure you've heard of Lyme's disease at one point, but that would be like a systemic inflammatory disease from ticks. I added this on here, and I can give this to you guys too if you want it. In terms of stages, you don't need to characterize which goes in each stage. I'm just trying to explain to you that they can actually have, present in multiple areas. Like they can just have a local rash and not really have problems with it. A lot of these patients, if they do have symptoms, they are going to be treated. We're going to be treating them with antibiotics. Tend to use doxycycline in these patients. And a lot of time is to prevent them from having like a late problem, or like a Lyme's disease state after getting bit. But they can have, like a general flu-like symptoms. They can have more severe, usually what you would see is more of like that characteristic joint pain, chronic fatigue. It's not that common to get like meningitis or anything like that, but it can happen. But a lot of times with Lyme's disease, they just tend to have a lot of chronic fatigue and a lot of joint pain in the future from it. So that's why we try to treat them early, essentially, if they do have, symptoms there. Other benign tumors, seborrheic keratosis is kind of like seborrheic dermatitis, like I mentioned at the beginning, and it's basically just proliferation of cells there. But they look flaky. You'll see it a lot in the older adult. I have images on the next slide. Keratoancanthoma, sorry, I can barely pronounce that, but it's usually from the squamous cells, and it usually begins by like the hair follicles. The big thing with it is that it can turn into like actinic keratosis, and actinic keratosis is almost like a pre-malignant state, essentially. You'll see these a lot in the older adult. I think if I show you an image on the next slide, it makes sense. Nevi are basically just moles. That's all that is. So it's either benign pigmented or non-pigmented lesions. So that's just all what nevi are, essentially. Seborrheic keratosis, very common. You'll see this on the older adult a lot. And so it's just like epithelial cells that are kind of collected on there. It's not, like a precancerous lesion. But when we see actinic keratosis, where it's looking like this, a little bit more raw, that is more of a red flag because it can present, or turn into like a carcinoma, essentially, or skin cancer in that area. So with these, they tend to, like dermatologists will tend to treat these or, kind of use chirotherapy, like freezing them essentially off because we don't want them to progress to something different. But these are very common. I'm sure you probably talked about in assessment, like the ABCDs of assessing the mole or a nevi, like the asymmetrical border, greater than 1 centimeter, does it itch or does it bleed? Those are things that are kind of like those red flags. So I'm sure you probably talked about that in assessment. Skin cancers, the most common one is basal cell carcinoma. Basal cell carcinoma, not that it's good to have, but it's probably one of the better ones to get out of all of them. It doesn't usually spread. Not to say that it could never, but it typically does not because it usually doesn't connect with that lymphatic system. So metastasis is very rare with it. However, they do need to be removed. I'll show you an image of it though. But a lot of times these actually kind of ulcerate. Sometimes they have like a dip in the center of it or they have crusts along it. And usually they're more firm. But this is very common, and you should obviously have them removed because they can progress, or get larger. And they basically kind of eat down into the tissue. So you want to make sure that they're removed early. Squamous cell carcinoma is basically of the squamous cells. So the other ones are basal cells, and the other one is of the squamous cells. It can spread, but it's very rare. It tends to start kind of integrating other tissues. So it's more invasive than basal cell would be. It's the second most type of skin cancer, essentially, but it's not as severe as like melanoma. Melanoma can spread very easily. I'll show you a picture on the next slide. Squamous cell, there's different types too, like they could be flat or they could be nodular. But with this, both of them, they can actually become friable where they bleed a lot or they itch. So those are kind of like the red flags that you'll see with it. But both of these need to be removed. Basal cell, like I mentioned, they tend to get like an induration there. They might have like a little border on it. They do need to be removed. Both of them need to be removed. Melanoma is a big one too. It's not as common, but it's the most serious skin cancer because this can spread. It begins in the melanocytes, which is what gives your skin pigment, but it is malignant. So this can spread, through your lymphatic system and cause, other cancers essentially, or spread to other organs essentially with that. So melanoma is a big one. Kaposi sarcoma is very common with HIV. Used to see it a lot in HIV patients. Now that we've treated HIV patients more aggressively and there's a lot more treatments out for HIV, it's become less common. However, it still exists, that's for sure. So basically with this, it is associated with a herpes virus too. So there's another link there with a virus that kind of triggers it as well. But remember with AIDS or HIV, their immune system's compromised. So that's why they are at more risk of developing things like this. It's a vascular malignancy, but is heavily associated with immunodeficiency. So you aren't going to see this in the average patient. You'll see this in a patient that is decreased immune response, essentially. They present as these like dark brown purplish lesions. They tend to get them on their trunk a lot. Like you'll see them a lot on the trunk. You might see them on the legs, but a lot of times they're in that trunk area. But they can even actually develop them internally. You can get them in the mouth. And even if like it's very severe, they've actually noticed them on organs as well, like internally. So it can definitely spread. But the big thing is making sure that their HIV is being treated appropriately. In terms of burns, this is one area that I did want to kind of cover, and I'll talk to you guys about it tomorrow too when we meet. But first degree burns, basically, just know the difference because first degree burns is really only the epidermis area, and I have pictures on the next slides, but it's that surface. The thing is that with first degree burns, and even like superficial partial thickness, they have a lot of pain with this, okay? In comparison to like a third degree or full thickness, when they have a third degree burn, they tend to start losing like that nerve, it destroys the nerves there essentially. So they will have no pain, and I'm not saying that they don't have any pain, but there's a lot of pain associated with like first and second degree burns. And it makes sense. Like if you think about if you burn yourself and you get like a first or second degree burn, they hurt really bad. But when you start getting deeper, those nerve roots are actually destroyed. So they tend to not have as much pain with it as they would if like a first or second. So first degree is basically very localized on the top, epidermis only, and it presents with redness. Just kind of like a typical burn that you would think of if you just burned yourself. Now second degree is kind of divided out into two separate areas like superficial partial thickness and then deep partial thickness. Superficial is like obviously your epidermis and some of your dermis, but when you get deeper, they go all the way through that dermis, and basically it's through both epidermis and dermis. A lot of times, like going back to first, there's usually not a scar, but they're very painful. With superficial partial, they tend to have blisters with this, and I'll show you when we go through the next slides. But the nerves are still intact, so they tend to be very, very painful. So the superficial tends to present with blisters. Deep partial, they tend to not have blisters because they're already kind of through that. It's more invasive, essentially. But deep partial can actually take weeks to heal. And it's not uncommon for patients to have tissue necrosis with deep partial as well. Third degree, like I mentioned, they tend to not have a lot of pain with it because it's going all the way down through that dermis, epidermis, and even the subcutaneous tissue. That's what we call like a full thickness. But these patients, if it's involving let's say an arm, like if it's going around the arm, like in a circular fashion, they're at risk for compartment syndrome, which I'll talk to you guys when we go through musculoskeletal, but it puts pressure on the underlying nerves, the muscles, the vasculature, so they're at risk for even other issues like compartment syndrome. We'll talk about that too later. In terms of fourth degree, a lot of times these patients with fourth degree burns, they end up having to have grafts or, basically a very, very detailed wound care essentially with it. It goes through the epidermis, the dermis, and then the subcutaneous tissue, and it can affect obviously their tendons, muscles, and bone. So fourth degree are very, very deep, but a lot of times these are those patients that require grafts and all that. When we look at body surface area for estimation of burns, they use what we call the rule of nines. The rule of nines, it has to be modified too when you look at the pediatric patient as well because their body surface area is different than an adult. Like for instance, a baby has a much larger head than an adult would. But we use the rule of nines essentially to establish the amount of total burn surface area because it basically supports the treatment that's going to be provided to the patient. When severe burns occur, like if they have like a greater than 25% of their body burned, or it kind of depends on the patient and where it's at, or how deep it is. But they use this for an initial strategy to, like institute treatment in the patient, and a lot of it is related to fluid resuscitation in the patient. And I'll talk about that as we move through. But we use the rule of nines to determine the body surface area. There's also the Lund-Browder chart. Here, I'll show you. Wallace rules of nines, it applies mainly for the adult. So when you're looking at the adult, let's say for instance they had a burn to the anterior portion of the chest, an abdomen, and the posterior portion of the back. You're calculating, all you're doing is adding it up. Like legs, it's just using the rule of nines. Everything's kind of proportionated to nines. So the head and neck is 9%, the entire head. The arms are 9% each. So let's say you had a burn on the front of the chest and or both arms. Let's just do an easy thing. They have, right and left arm is burned. It would be a total of 18%. So all you're doing is adding it up. It's just to give you a quick ballpark of what's burned or how much is burnt to initiate treatment. The Lund-Browder chart is basically used a lot. You don't need to memorize all these, obviously, but you should know this, because it's one of those things they ask you about in NCLEX. So it's good to just learn it now, but know the amount. Like anterior is 18, posterior is 18, arm is 9, other arm's 9. So make sure you add all this up. The genitalia or perineal area is 1. In kids, it depends on the age of the child. Sometimes the length or like they'll measure the head of the baby, but it's a little bit different than the adult. But right now, don't worry about the pediatric. They'll cover some peds too. These are just examples of first degree. Remember I mentioned it's just basically that superficial burn. This is literally like a sunburn, or it could be a burn like if you spilled something really hot on your skin. Second degree burn, it could be superficial partial or deep partial. So superficial, remember they have like blisters with it. Where it's deep, they start to go down more into that epidermis essentially with it. So that's a second degree. Third degree, it's basically where they start to have full thickness, so they're going down with the subcutaneous tissue with it. They can have tissue necrosis with these. But like I mentioned, a lot of times when it's like a circumference of an extremity, they're at risk for compartment syndrome too, and we'll talk about that too. Fourth degree burns, unfortunately, I know this looks terrible. They can go very, very deep. And what happens too, like this actually looks like they did a fasciotomy. When I mentioned compartment syndrome too, All that pressure, because all the swelling and fluid accumulation under there, it puts pressure on the nerves and the vasculature there, which can cause tissue damage or nerve damage. So they actually will have to open up the compartment to release the pressure. And I'll talk to you guys about that tomorrow too. I already added this on the other one, sorry. I added another slide, but I can give that to you guys if you want it. But anything greater than 20% of total burn body surface area is considered to be a major burn. And like I said, it determines our treatment because they have a huge, significant, massive loss of water. And I'll explain this in a minute, but they get hypovolemic essentially. So at the very beginning, it's crucial to make sure that we're essentially replacing fluids. They end up with hypovolemia. They have decreased cardiac output. It can affect their organs, like their kidneys. It can get renal failure. So when you look at it as a whole process, it turns into a systemic body response essentially. But they can go into what we call burn shock. It's very similar to almost like a hypovolemic shock essentially. So burns greater than like that 20% or 25% require like really early fluid resuscitation. And that's what determines the amount of fluids and, that we give depending on how burned they are or the surface area. For instance, like another thing, like if a patient is burned over 40%, they always there's guidelines saying basically you need to have 2 lines in the patient, sort of 1 line, like IV lines. It's just basically to kind of determine the treatment protocol for the patient. Or even patients that have greater than 10%, a lot of times they're transferred to a burn unit. So we use it as a guideline to, or a protocol for treatment. This one I added too. I just added this because about the rule of 9s with an adult patient, but babies it's a little bit different, and that's where they use that Lund-Browder chart essentially for it. This is another thing that I added too because it might be useful in terms of let's say somebody had burns that were sporadic, like they only had it in certain areas, but they had a lot of them. You can use your palm, the patient's palm or the size of the palm, because obviously it varies between pediatric and adult. One hand essentially is 1%. So if, let's say they had a burn on their leg, if you took the average of like a palm or their hand, that would be 1%. Same thing, they say 0.8, but literally it'd be 1%. If it's half the palm or only the base of the palm, you would say that's 0.5%. So if they had burns that were kind of separated all over the body, you could use this as a method to determine burns. Or sometimes they'll use it for burns that are less than 15%. In terms of a response with it, as I mentioned, it's a huge systemic response. So remember even when we think back to like that inflammatory response that we talked about at the very beginning, where it's a systemic response. So it's a huge, even like you think about like when we talked about like anaphylaxis, it's a systemic response. It's very similar. Like they have a huge shift in fluid. They have a lot of fluid loss with it. So what happens is they get hypovolemic. That's why we have to make sure that we're resuscitating fluids very quickly and pretty significantly. Because obviously what happens when you have hypovolemia, you have decreased cardiac output, which then, therefore, you have decreased perfusion. So obviously then it becomes, a systemic issue when you're not perfusing well either. But there's a lot of movement, of fluid and protein. So they tend to have like hypoproteinemia. Remember when we talked about albumin maintaining that intravascular space or intravascular fluid volume. So they'll tend to have a very significant shift in fluid. They tend to end up with like an elevated hematocrit because all that fluid shifting out of the intravascular space. They're getting essentially a fluid shift there with it. They may have an elevated white count with it too, and a lot of it's because of the fluid shift that's going on. But obviously they can go into shock because of the fluid shift there. There's cellular response to burn injury too, which basically can disrupt that membrane potential of the cells. I mean, if you think about it, there's damage to cells there. So it can impair that sodium-potassium pump. And there's increased intracellular sodium in water. So if you think about increased sodium in water in the cell, what happens? It swells. Sodium in water, it's going to cause cellular swelling. Because of these disruptions, they may have a decreased potassium as well too. But really, like when they have profound shock, it affects your organs. That's why, like even if You think about the liver, it can affect your liver. And when your liver is affected, it can affect your clotting. So you can have, these patients are even at risk for like DIC, where they have extreme clotting and bleeding because of the liver dysfunction as well. So it's a multi-system or systemic response essentially that occurs with this. Metabolic response is a huge thing too. They have a huge significant increase in metabolic rate, especially during that first day, first 24 to 48 hours. But this can persist for a very, very long time following a burn, up to 2 years. It's not to say it's as significant as it is at the beginning, but it still could be there. But they get this hypermetabolic state. So it's a significant state of metabolism, essentially. And it alters levels of like your cortisol. It's like a stress response, your sympathetic nervous system. There'll be a release of glucagon, basically to support this hypermetabolic state. There tends to be insulin resistance with it. So a lot of times too, we have to make sure that we're treating like their glucose levels, because they tend to have hyperglycemia with it too. So we'll be, making sure that we're giving them insulin and all that, which we'll get into with pharm. But there's a significant inflammatory response with it, recruitment of inflammatory cells at the site of injury. They're at relative risk for immune suppression. So that's a big thing with burns too. So not only are they, they have the opening in their skin that puts them at risk for infection, but their immune system becomes dysfunctional because it essentially is going to that site of injury, and it doesn't work great for infection. So they are definitely at risk for sepsis. The other thing that occurs too is that this hypermetabolic state, plus on top of having a significant burn area or significant body surface area burned, they are at risk for temperature alterations, essentially. So if you think about the skin, your skin is a major organ for maintaining body temperature. So if they have, an opening in the skin or a severe amount of area of burns, they have a difficult time holding their temperature, essentially, with that too. So not only does the metabolic state kind of affect the regulatory set point, but they also have issues maintaining their temperature. So at the beginning, like, you hear terms like cool the burn, but warm the core, because in any trauma patient, whether it's a burn or patients, there's a lot of issues with maintaining their body temperature. All that fluid, is released, and then they have evaporation of fluid, and they don't have that tissue there to hold their temperature anymore, essentially. Immune response, I kind of already mentioned this. Obviously, at the end, they have a very prolonged immune response due to the injury, but they are at risk for immunosuppression as well. And also, too, wounds from burns, they're at risk for sepsis. Evaporative water loss, once again, I already mentioned, they're basically at risk for fluid volume deficit, so they could have hypovolemia. So they have evaporative water loss, and because of the fluid shift, they have water loss from that as well. And then also, too, they can actually lose it through the respiratory system or the hyperventilation, essentially, as well. So basically, that's why another reason why we do a lot of fluid resuscitation with these patients. It's got a very complex, prolonged recovery, and there's a lot of complications with major burns, whether it's wound healing or insulin resistance. Things like that can occur with this as well, or even contractures of the skin, and I'll show you that in a minute. The goal is wound debridement and closure in a manner that promotes survival, so reducing infection and removing necrotic tissue as well. Scar formation can occur as well with contractures, and it's often a consequence of those deep partial thickness or third-degree burns. And I'll show you an image in 2 slides, but it's really important too. I mean, it's important for the entire body, but like when you think about burns of the hand, it can be very detrimental to a patient, because they can actually develop contractures with the skin, because the skin starts growing in altered patterns, and they can't move their hand well, essentially, from it. So it's a huge problem. And then I have another image 2 slides down, but like even the axillary fold of a patient, they have difficulty moving their arm because of, where the skin started to grow, essentially. So elements of survival, the big thing is making sure that we have early fluid resuscitation on that patient. Nutrition, so a lot of times these patients obviously are going to have enteral nutrition. Because of the hypermetabolic state, we have to make sure that we're supporting that. Meticulous management of wounds is a huge thing. early surgical excision of necrotic tissue, skin grafting, because even like to maintain their body temperature and all that, it's important for that too. A very aggressive treatment of infection, because obviously it can spread and they're already immune compromised as it is. Promoting thermal regulation. So a lot of times too is making sure that these patients are staying warm, after the burn as well too. This is basically like what I was mentioning. Like you can get a contracture that develops, in folds or of the armpit, and then they lose function of, their extremity or their hand because of the tissue growth there. So that's why too, like early grafting and all that is necessary too, so that we're making sure that the tissue is regrowing in a fashion that will not cause contractures in patients. Hypertrophic scarring is relatively common with it. It's kind of like this kind of is similar to like a keloid, where they start to get thickened tissue in that area. But once again, when it's on the hands, you have to be very careful, and we monitor that to make sure that they don't lose function of their hands as well because of it. The same thing, you can have cold injury to skin. Same kind of concepts with tissue necrosis in terms of cold versus hot. So obviously patients can get, frostbite or frost nip. Essentially, frost nip is just like it's not as severe as frostbite, essentially. Frost nip is basically reversible, but they tend to have more of that pallor or numbness in the area, so it's mainly white. However, obviously we worry about it becoming frostbite, essentially, or more severe. Very common in those areas like your fingers, toes, ears, nose, because of circulation. So if you think about where it presents, a lot of times it'll be at the tips of fingers or, the tips of toes, because circulation to those areas is not as great as it would be to like your core body, essentially. So that's why it occurs in those areas. But at the beginning, it's reversible. Chilblain, you don't hear that term used that often, but basically it's like a purplish color. Violaceous color basically means purplish. So they tend to have more of like a ruddy color or purplish color in that area. But they tend to have it's not severe tissue necrosis or anything like that, but it's more severe than like frost nip essentially with that. In terms of cold injury, frostbite, so basically if the tissues freeze over, and that's actually literally freezing of the tissues in that area, and they actually get ice crystal formation at the cellular level. But they tend to present with numbness and no sensation, or loss of sensation in the area, and they tend to not have pain there until it actually starts thawing, essentially. But then they present with very severe pain, and they can get tissue necrosis with it. Obviously, this is a very severe state of it. But once again, it's classified by depth of injury. But if it's severe enough, like if it's the toe, it puts them at risk for gangrene, tissue necrosis, and then, amputations, unfortunately. Flash freeze, this is more common like if it's quick, meaning flash. Flash means basically fast. Like that would be if they had some kind of liquid that is a freezing agent on their skin. They can basically end up with like a burn type injury from it. Typically, it does not tend to cause deep tissue necrosis like this. It's more superficial that they get it with. But we'll talk about herpes zoster a little bit more in detail in class, just to make sure you guys don't have questions on it, and then burns too if you have questions. I just wanted to add this in case you had, you need any further help for the assignment, essentially. So if you have questions today, obviously feel free to reach out to me, and I will see you guys soon. Thanks. Have a great day.